Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone to the Interventional Radiology IR Fellows Review course. We will start our first lecture about vascular Doppler ultrasound with Ms. Mona Zahrani. She's a senior technologist in King Faisal Specialist Hospital, Riyadh, Saudi Arabia. الله يعطيك العافية دكتورة منى، وأتمنى من الجميع اتباع التعليمات اللي وصلناها في جروب. إذا كان في أي questions, we'll keep it toward the end. Just raise your hand and wait for your turn. بالتوفيق. تفضلي.
So today we'll talk about arterial duplex scan, but before that we're gonna mention about the hemodynamic and vascular anatomy of the arterial Doppler. Hemodynamic, the definition of the hemodynamic is the study of the movement of the blood. Study of the movement of blood and the forces concerned within the vessels. And also describe the forces or mechanism involving in the regulation of blood flow within the body. Volume of a blood passing through the vessels per unit, we called it the Q flow. We claim that the flow always moves from the highest pressure to the area of the lowest pressure. For example, in the left ventricle here, the blood in the left ventricle is higher, so that's make the blood move from the high area to the low pressure to the right ventricle of the heart. Two equation is important in our vascular lab. Bernoulli Effect describe the reduction in pressure that compensate an increase in velocity, responsible for lower pressure downstream from stenosis. Bernoulli principle state if Q flow rate is constant, a decrease in area causes increase in velocity. So as velocity increase, pressure will decrease. We see here inside the vessels, flow constant in the vessels. There is no reduction, no stenosis, it's open vessels. So velocity stay the same, unchanged. Pressure constant also. In case of any reduction or stenosis, we will see what? Flow before the area of the stenosis, constant. And the pressure at this area, it will be high. At the area of the stenosis, the velocity will jump up, and we will have high velocity at this area. What will happen to the pressure there? It will drop down below to the stenosis area. So this is the principle of the Bernoulli effect, and we use this equation when we do the ABI study for the vessels, yani most likely. Poiseuille's law describes the relation of blood flow to pressure size of the blood vessels and the thickness of blood. Different pressure equal Q flow and a resistance. Resistance so depend on viscosity, length, and the radius. Flow rate of the blood is directly proportional to the pressure difference within the vessels times the fourth power of the radius times fourth power of the radius. So the radius here is very important factor. This is our fabulous equation in the vascular. You will see like different parameters of in this equation. Q flow, Q, which is the flow, difference in the pressure gradient, length also, parameters of the viscosity, of fluid and the radius. And these parameters affect the flow of the vessels. Like pressure gradient, if we have pressure gradient, this is directly proportional to the flow. Velocity also directly proportional, area directly proportional, resistance indirect proportional. Decrease resistance by increasing radius, decrease length, decrease viscosity and friction. As we said, the radius is the most important factor. Here, if we have small changes in that, this is the normal, and if we have like reduction in the vessels, we'll have significant change in flow. And flow is proportional to the radius of the flow is proportional to the radius, the fourth power to the fourth power. Length also, it's another parameters effect. Like if we for example, the ECA, external carotid artery, is very elongated, and so the resistance inside it's high resistance. Compare with the ICA, that's very wide and open, it's less resistance. Viscosity also, as the viscosity increases, friction and resistance index increases. Flow is indirect proportional to viscosity. We see here in the normal blood vessels, pressure difference across segment of the vessels remain unchanged. Flow decreasing significantly as diameter decrease. You see here open vessels and there is no reduction. So this is a normal blood vessels. In case of there is abnormality, diseases, blood vessels, try to maintain, as you see here, there is reduction in the vessels. So the flow inside the vessels, he tried to maintain the same amount of flow. So pressure before the stenotic area here will be high, and pressure after stenosis area, it will be dropped down. And the velocity at the area of the stenosis, it will be very high. So decrease in diameter causes an increase in pressure gradient. There is different, this is high and this is low. That's why the blood try to compensate to the low, to the area of with low pressure. And also velocity at the stenotic area, it's getting high. Arterial hemodynamic, high pressure system, between 70 to 100 millimeter micro. Blood flow is created by bumping action of the heart. Flow pattern depends on location, depends on the size and the course of the vessels within the body. We have different type of flow patterns. We have what we call laminar flow. Laminar flow, if you have the vessels, this is like vessels. The velocity of the vessels in the middle of the vessels, the velocity will be higher than the velocity close to the wall of the vessels. That's why we usually, when we do study or Doppler, we always try to sample in the middle. We want the highest velocity of the vessels. So do not like take it close to the wall, because the velocity close to the wall, it's lower than in the middle. This is what we called it laminar flow. you see here, it's open vessels, and the area close to the wall, you see more redness here. It's because the friction, the viscosity also, it's high here. But so when we sample in the middle. This is normal laminar flow. And we use this like terminology also in most of the reports. Blood flow, we usually see it in the large vessels, like the aorta. The velocity inside, because it's wide, so the velocity inside the vessels, it will be the same. Yani in the middle, same as the close to the edge of the, because it's very wide vessels. And this is, we usually see it in the aorta because the largest vessels in the body. Turbulence flow, blood flow is flowing fashion, some in the opposite direction. You see here, with stenosis area or the reduction in the stenosis, what we see here, all the blood try to move through the stenotic area, and what will happen? Opposite direction. We see like opposite direction of flow at the exit of at the entrance and at the exit point of the stenosis, responsible for large pressure drop that occur after stenotic lesion. We see here, as we said, the pressure post-stenotic area will be dropped down. Change in direction causes an energy loses. So we'll have lose energy after the stenotic area. We'll talk about waveform. We have two types of the waveform: high resistance waveform and low resistance waveform. High resistance, it's waveforms. It's we called it normal. We have triphasic and biphasic also. So triphasic and biphasic, we consider it as high resistance. Reflected wave causes reversal of a flow. Example, we see this type of flow in the extremities, in the upper and lower extremities. Also, we see it in the superior mesenteric artery when we have empty bowel or when the patient fasting. Second type of waveform, low resistance. Low resistance, or we called it monophasic waveform. This monophasic waveform, one direction of flow during cardiac cycle. We see it one direction. There is nothing lower to the baseline. And we usually see the low resistance waveform or this kind of flow supply the organs like the brain and liver and also the renals. So this is what we call low resistance. This is the difference between systolic and diastolic. And greater difference increase pulsatility, supply information about distal arterial beds in between both pulsatile waveforms. Arterial waveforms, the characteristic of Doppler waveform for an artery depend on the characteristic of the arterial beds to which the artery is sending blood, not the identity of the artery itself. And if flow goes to the organ different than flow goes to the extremities. Another type of flow, what we call it post-stenotic turbulence, occur at the exit point and just distal to the significant stenosis. represented the turbulence flow that compensates a stenosis, could have elevated velocity. Distal to the stenosis, like 2 centimeter away from the stenosis, we will have Tardus or Parvus Tardus waveform, which is monophasic flow, delay, obstruct with reduced velocity. So always when we see Tardus Parvus, a sign of very high stenosis proximal to that area. We see here effect of stenosis on flow. We have a vessels with stenosis. Pre the area of the stenosis, we will not have a normal waveform. Still, we will have what we called it pre-stenotic flow. I called it usually in my notes stressed waveform. There is nothing proximal, but the problem it's lower to that area. So we called it stress. It's monophasic. You see it here, but very high, sharp. So I'm using this terminology, just stressed waveform, pre-stenotic area. This is what we see if there is stenosis distal to that area. At the stenosis side, we have here high velocity, high peak systolic, high diastolic, and you see here abnormal waveform in the vessels. Post-stenotic area, which is like immediately after the stenotic area, turbulence. So this is post-stenotic area. You see still turbulence, and some of them is still with high velocity or peak systolic. 2 centimeters away from that vessels, we will have Tardus Parvus. Okay. Blood vessels wall. We have 3 layers of the arteries: tunica intima, tunica media, and tunica adventita. The most important here for us when we study it's the tunica intima and media maybe more. We see here the difference between the artery and vein. The artery is thick wall. Compare it with the vein, and the venous more wide than the artery. This is sometimes how to differentiate between the artery and vein. Okay. Arterial duplex scan of lower extremity. What is the rule of duplex for lower extremity? If you wanna study lower extremity, we usually have two ways to study the lower extremity. We have what we call BVR and segmental pressure provide a valuable physiologic information, but provide very little anatomical details. And also we can do duplex scan for lower extremity, and this can provide anatomic and physiologic information directly from sites of arterial diseases. The difference between the arterial, we'll talk about the difference later. Arterial duplex scan advantages, the advantage of the arterial duplex, non-invasive, inexpensive, provide physiological and anatomical information, can do routine follow-up exam. The limitation of this exam, the equipment itself, and patient body habitus, tech dependent. It's really important to have vascular tech knows what to do. Anyway, limited areas of view, does not account for collateral flow. Arterial duplex scan also the clinical rules to do the exam. We usually do it for screening and to definitive diagnostic and for follow-up, and also to study a bypass to evaluate bypass. This is the anatomy of the lower extremity. We start from the aorta, iliac divided to internal and external, and then the common femoral artery divided to profunda and the superficial femoral artery. And then at the knee, we have the popliteal artery divided to anterior tibial artery and to tibio-peroneal trunk, divided to posterior tibial and peroneal artery. To study the lower extremity, we have to start with blood, B-mode image or grayscale image, and color Doppler and pulse waveform Doppler. Three ways to evaluate the lower extremities with Duplex. B-mode, what's important to study the or to start with the grayscales image is just to evaluate if there is any plaques or any calcified vessels, or we cannot just start with the color or the spectral itself. Color Doppler also to see the patency of the patency, and if we see any abnormality by the color. And pulse wave Doppler, here we analyze the waveform for abnormalities. Here, the grayscale image, we can see the wall, and we can, make sure there is no plaques or something. Sometimes we need to play with the gain itself, so to see maybe there is plaques or atherosclerosis with still hypo, not become hyper. So we need to play with the gain. And it's important to know the orientation. This is the head, and that's the feet in the lower. And in the transfers also, this is right, and that's the left side. So we usually take longitudinal and transfer image by the grayscale or B-mode imaging. Should evaluate, we should evaluate the flow pattern at very close speed intervals, usually about centimeters apart. And in this way will be, if we study every centimeter of the vessels, the accuracy of doing the lower extremity, it will be high. I would say 99% very accurate, because we study each centimeter of the vessel, especially if there is there is reduction. In occluded vessels, color or power Doppler should be used to locate the point of occlusion and distal reconstitution by collateral flow. A complete evaluate start at the abdominal aorta and all the way down to the ankle. So standard protocol, we start from aorta, we take proximal, mid, distal, and then we go to the iliacs, we study common and internal, external, and we go to the common femoral artery, and then the original part of the profunda, we will not go more deep, just the proximal of the profunda to evaluate the flow there. And then superficial femoral artery, proximal, mid, distal, and the popliteal artery. And then we go to tibial and peroneal, or anterior tibial, and also the posterior tibial and peroneal artery. In case if there is any stenosis, we have to, take pre and at and post stenotic area. We have to, do pre and post. Okay, Doppler angle is extremely important, and interpretative criteria is based on Doppler derived velocity waveform. It's the most important things, and we always, the Doppler angle, it has to be how we play with this. It has to be parallel to the wall and do not exceed 60 degrees. And if you not see like a correct angle, please, doctor, do not mention velocity if the angle is not correct. This is my word to you. Velocity, the accurate velocity when we have parallel angle to the wall of the vessels, and in the middle, and the sample volume, in the middle of the vessels itself. And do not mention velocity in your report if the angle is not correct. Okay. Normal flow pattern, laminar, we have here, this is in the middle and parallel to the wall. And we have here the triphasic waveform. If you see here the clear spectral window, and this is really important because it will be in the criteria of to define stenosis, and we will see it later. So clear window here, and triphasic waveform. So and laminar, or laminar because it's in the middle of the vessels. So this is normal flow pattern. Abnormal waveform, when we have spectral broadening and increased peak systolic velocity at the stenotic area, turbulence signals just distal to stenotic, monophasic waveform with decreased peak systolic distal to high grade stenosis. Waveforms immediately proximal to occlusion will have low peak systolic with no diastolic flow. So this is normal lower arterial duplex. You will see here. This is proximal aorta. We have some artifact there because the motion of the heart. And distal, we start proximal and mid and distal also. And here you can see for the iliac, and we sample here the iliac. So we see it's all a triphasic waveform. Triphasic, and all are triphasic, even the posterior tibial artery, you see it here. Triphasic also, because it's open, there is no occlusion, no stenosis, so we'll have triphasic all the way down. Abnormal waveform, you see here, I have turbulence color. When I sample there, I have high peak systolic, high diastolic also, and mixed velocity. Post-stenotic area, you see it high velocity, and we lose the characteristic of the waveform. Here, Tardus Parvus is distal, or we call it 2 centimeter distal to the stenosis. Classification of arterial lesions. Normal, this is normal waveform, triphasic, and no spectral broadening, very clear window here, or clear envelope, okay? In case of there is stenosis, why I said the clear window is very important when we do the ultrasound Doppler, it's because it goes to the criteria of to define the stenosis. So from 1 to 19, still we have triphasic, or we call it biphasic, but minimal spectral. There is minimal spectral broadening, and velocity less than 30 increase. The peak systolic velocity less than 30. So the stenosis here from 1 to 19%. So it's very important to see the spectral window here below the waveform. From 20 to 49, still less than 50%. We have still triphasic. So we have triphasic. We have we lose here the clear window. We have wide spectral broadening, and also the velocity from 30 to 100 increase in peak systolic velocity. So that's why the stenosis less than 50%, from 20 to 49. From 50 to 99, here monophasic waveform, and spectral broadening, extensive spectral broadening here. We don't see a normal spectral window. Velocity more than 100, so the stenosis is very high, from 50 to 90% of the stenosis. Here, in case of the occlusion, we will have very low waveform, and there is no diastolic. In case of complete this waveform, we see it before the occlusion. So before any occluded vessels, we'll have this waveform, and there is no flow there. Here, in case of normal triphasic, all the way down, from the aorta all the way down, if in case of normal vessels. With the stenosis, we'll have, at the stenosis area, this type of flow. If there is any occlusion, as we said here, the stenosis area will have very weak flow, and there is no flow at all. And then lower to the occlusion, we'll have Tardus Parvus. Okay, lower extremity, we use it when we study the bypass graft, and we have different type of bypass: axillary, femoral, and femoral bypass, or arteriofemoral bypass, femoral popliteal anstio, and yeah, we have different. And how we study this, we usually, when we study this, we'll take the inflow here. We sample here as inflow, and add the anastomosis, and inside the graft, proximal mid-distal, we study the flow proximal mid-distal, and at the anastomosis area, and out of the vessels, we called it outflow also. Here. So we have two types of the graft, artificial and autologous vein, and situ vein graft, or reversal or harvested vein graft. Location, availability, and necessity will determine which type of graft is used. So classification of arterial lesion are the same as native arteries. With interstitial vein, graft must look for recanalized or missed branch. For reversal vein, we have to look for calcify the valve itself, because we might see it calcified. So we might mention there's like something abnormal, and maybe the valve itself. Okay. Here the protocol, as we said, proximal inflow artery and proximal anastomosis, proximal mid-distal within the graft, distal anastomosis, and distal outflow artery. Reason for failure, graft, when we have poor outflow and inflow, poor inflow, stenosis within the graft, progression of the of disease. Also, we study the Duplex scan to rule out aneurysm, focal increase in size of 1.5 or more. Yani this is the vessels here, and increase the size of the vessels to the half تقريبا. Most common type in the popliteal and common femoral artery, superficial femoral artery, subclavian artery can be source of imply. Pseudoaneurysm, we study arterial duplex to rule out pseudoaneurysm. Also, small bucket of moving blood flow, which is connected to an artery through a small opening neck, you see here, caused by trauma or cardiac catheterization. May contain some thrombus at times, identify as pulsatile palpable mass in the groin. Pseudoaneurysm pseudoaneurysm has really typical waveform, to define this is pseudo or no. Just sample at the area of turbulence. If you see this flow here, this is we called it pseudoaneurysm. So this is special wave Doppler and for the pseudoaneurysm. When we sample at the neck, so this is the typical waveform of the pseudoaneurysm. The treatment usually do ultrasound guided compression, thrombin injection, and surgical repair. Dissection, this is very important also, especially for patients if they had surgery. Dissection involves a tear in the intimal layer of the vessels. Tear allow blood to flow between the intima and media, creating a false lumen. Blood flow can push the intima flap across the true lumen and completely occlude it. Appear on ultrasound as double lumen with bright echogenic intima lumen flap. Can happen spontaneously or traumatic. If you see here, this is like tear ones inside the vessels. So when we put color, we see flow around the echogenic tears there. When we sample, we see like backflow, peak systolic and diastolic lower to the baseline. It's like, same waveform up and down. So dissection is very, important also to evaluate. Arterial venous malformation, and also for the arterial venous malformation, an abnormal connection between native artery and the native vein. Ultrasound findings increase peak systolic and diastolic waveform. Pulsatile will have pulsatile venous flow. That's why you usually before the area of the abnormality, like if we check the groin area, we have to go and check the venous, below in the thigh, before the area of the groin, if it's pulsatile or no. Can happen spontaneously or traumatic. Can be symptomatic and asymptomatic. Here, this is the opening between artery and vein. Now we'll talk about non-invasive arterial pressure and waveform for the lower extremities. The goal of any non-invasive arterial exam of the extremities is to answer 3 questions. Is there any vascular disease? And how much is present? And where is this disease located? Duplex, the difference between duplex and the pressure testing. Duplex, it's direct to the vessels. Can located focal stenosis. For the pressure, it's can only located level of the diseases. Duplex scan cannot evaluate the amount of perfusion. For the pressure segment, we shows total perfusion, including flow from collaterals. And we usually have like requests to, they asking for ABI just to know about the perfusion, even if the vessels is occluded, or the vascular surgeon, they just want to know if there is any perfusion in that leg or no. Also, the duplex scan limited due to the body habitus. The limitation of the pressure testing due to the calcified vessels and multi-level disease. If the patient, especially for a diabetic patient, they have like calcified vessels, it's very difficult to occlude the vessels and do our test. So this is the limitation of the machine or the test. Vascular symptoms. Vascular symptoms are caused by reguinal area of hypotension within the limb. These low blood pressure are the result of presence of occlusive disease and lack of adequate collateral circulation to the affected area. In this test, we use the Bernoulli Effect. Segmental pressure utilize the peak systolic pressure at the difference level to evaluate for pressure gradient. The peak systolic pressure are also divided by reference pressure, highest brachial area, and create ratio nose pressure index. Before beginning exam, you should obtain medical history. We have to ask the patient, are you diabetic? Do you have hyperlipidemia? And we ask him about the pain. Is it related to exercise? Do you have the pain when you exercise or when you are resting? So this is like important question before we start the ABI study. Always bilateral. We use the calves or placed in brachial artery, bilateral, and high thigh, low thigh, at the calf, at the ankle, metatarsal, and greater toe, and bilateral extremities. Calf size are usually 20 centimeter wide for the thigh and 10 centimeter wide for brachial, calf, and ankle pressure. And there is special cuffs for the toe and the metatarsal also. You should always attempt to use the largest cuff possible to prevent a common artifact known as cuff artifact. Cuff artifact is false abnormal high systolic blood pressure reading with which is obtained if the width of the cuff is less than 50% of the diameter of limb being measured. See, the width of the cuff should be less than, we'll have cuff artifact if the width of the cuff less than 50% of the diameter of the limb. Different type of the cuffs we using it in the with the ABI machine. All Doppler signals for this test are obtained by using two probes, 4 and 8 megahertz continuous wave Doppler probe. Toe pressure are usually obtained using PBG. Bilateral brachial pressure should be obtained first as we use the brachial pressure for reference. Next, obtain the segmental pressure at the of legs working from distal to proximal. We start usually from the ankle all the way up to the thigh. Can use posterior tibial and the dorsalis medius artery as reference for the thigh and calf pressure. As minimum, you will require to obtain one of each posterior tibial and dorsalis at the ankle level. It is important to remember that the pressure reading obtained is pressure of blood within the blood vessels, which lies underneath the cuff, not the pressure of the distal vessels used to measure the return of blood flow. So usually any reduction or anything usually at the area of the cuff or superior to the level, not below, no, above. Pressure index, a way to compare the lower extremity blood pressure to the individual systemic blood pressure. A ratio obtained by using the limb pressure and dividing them by the higher of the two brachial pressure. The most highly utilized of these index is ankle brachial index. Ankle brachial index for non-diabetic patient, it will be 1. This is what we, look for non-diabetic patient. Can be falsely elevated due to calcified medial layer of the arteries, and ABI greater than 1.25 is considered falsely elevated. We'll see slightly difference among the institution. Toe pressure, brachial pressure, and normal, usually more than 80% of the brachial pressure. A normal TBI is 0.50 or greater. Digital arteries are usually spread from calcification. Here, the ABI range more than 0.96. This is, we consider it normal. From 0.95 to 0.50, claudication. Claudication is the pain that comes with when the patient doing exercise. When the patient complain of pain during the exercise, usually we call it claudication. Wrist pain, this is, it will be more less than 50 or from 49 to 0.25 wrist pain. and this is really worse. Necrosis and tissue loss if it's less than 0.25. Pressure gradients. The difference in the systolic pressure between any two adjacent levels should always be less than 20 millimeter micro in non-diseases levels. Difference that exceed more than 20 millimeter mercury, usually indicate that some occlusive arterial disease is present within the segment having the lower pressure or above it. It's always possible to compare right to left. Level of disease, aortoiliac inflow, femoral popliteal, run of tibial outflow, distal small vessels, and multi-level of disease. Volume recording, this is really important. And the most important things, the most important here about pulse volume, how to read it. If you see here in normal, we have 3 components. You know, the pulse volume recording, this is important about this for the perfusion. We have 3 components here, anacrotic limb and catacrotic and diacrotic. And this is, we call the typical normal, very good amplitude, you see it here. We have, 5 categories of diseases here. This is the normal, all the components, it's there, 1, 2, 3. So this is normal and good amplitude. If we start, if we have like mild disease, this is category 2. We lose here the what? We have the anacrotic, but we lose the other two component. So here mild disease, because the amplitude is still high, so it's okay. But this is mild disease because we lost the notch distal, the amplitude. Category 3, moderate disease, when we lose the amplitude, but not less than 5 centimeters. So we lose the amplitude here, and we have anacrotic, but there is no diacrotic notch here. Here the amplitude less than 5 centimeter. So we have category 4, moderate severe disease. And if we have category 3, we have 5, we will have severe disease with flat waveform here. So amplitude is important, however, the shape of the waveform holds more value. I know there is no time, but I left some here chart if you wanna just see it, and you can question me if there is any question later. But this is, you can see BVR here is normal, and the ABI here is all normal, except this area here. There is reduction in the pressure less than 20. So that's why we start having the diseases. Here we lose the amplitude, the notch, so with present of the disease. I can help you guys later, but I think we are run out of the time. No, we have 1 minute, so.
I think let's continue with these examples. It's really important for them to see it.
Yeah,
if you
okay, okay, good. So if you see here, the volume, the BVR, we call it the BVR. It's very important, doctors, for you know, to evaluate the perfusion. So if you want to read here, if you see here the amplitude, it's high, the all three components are there. So we consider this all the way down normal. Even here in at the toe, we can see the 3 notch there, or let's say 2 notch. So, but we consider it normal. Here, if you see the pressure, طبعاً, brachial artery on the right side, 111. We will go with the brachial. So our reference here, the left brachial artery, 127. So here, 138 at the thigh. It's higher than 127. So we have normal ABI. At the low thigh, we have 49, which is normal here also. The ABI one, and at the calf here, still normal. Here, still normal. Here, still normal. At the digital here, we see less than 20 millimeter mercury. So here we start seeing the disease, even in the other side here. We'll see another chart. If you see here the pressure at the thigh, the reference here, it's 160 in the left and right. So 160, we see it at the thigh. ABI is 1. Lower thigh, 164. At the calf, see here, we lose, the pressure dropped more than 20 here. So we start having the disease. 0.8, the ABI. And if you see the chart of the right here, see, at the calf. Yeah, see, we lose the anacrotic. This is what's called it mild disease. Diacrotic, we lose it here. So we called it mild disease. If we want to compare it with the pressure here. For the left side, we have drop in the pressure where, I think here. Yeah, I think below the thigh, in this area here. So the pressure at the calf, 148 compared to 160. So we start have disease. We can see it either in the calf or above the area of the in the knee, and above the calf. And also the amplitude here has become different, the BVR. The index also, it's start to be less than 1. We call it mild disease maybe here. And the blood, the pressure continuous the same, 148. So there is no another level of reduction here, stayed the same. So it's mean the problem only at the thigh there. Sorry, at the knee or above the calf. Another chart here. If you see here the abnormal amplitude from high thigh all the way down. This the disease here, it will be in the iliac, guys. If you see here high, the brachial, my reference here 162. So 162, compare it with the high high thigh in the right side. This is drop 122 compared to with 162. So I have drop in the pressure at the area of the disease, and it's affect all the BVR all the way down. If you see here, if there is like multiple stenotic, you will see from level to the level drop in the pressure. It's clear or no? But this is with iliac disease. Here in the left side, we see here 162. This is my reference in the brachial. At the upper thigh, we have 174 that will have normal, and even the amplitude here is normal. Low thigh, we have 165, still normal. At the cuff, there is reduction here in the pressure, so less than 20%. So here we have already the difference in the amplitude, if you see it here in the cuff area. If we go more, see here with bilateral iliac disease, or maybe in the aorta, this one. So abnormal BVR all the way down. And also the ABI, it's abnormal in bilateral thigh. So this is usually here the disease in the either aorta or the iliacs. What I really like, I wanna say something. It's very important in our vascular lab. I really prefer started with the ABI, because this is give me like an idea about everything in the circulation of the body. Even in the brachial, when I test the brachial artery, right or left, if there is any occlusion or something in upper extremity, I would recommend that in our study. So it's give you like a map for where's the area itself. And then after that, because when the patient going to the interventional, okay, we go more further with the Duplex, arterial Duplex scan to show the location of the stenosis and how much, and gives more details, and that's it. Thank you so much.
Thank you very much, Mona, for this very comprehensive review on Doppler ultrasound. I know she is, just to let you know, Mona asked for a full day workshop and I squeezed it for 1 hour. Otherwise, she was running especially towards the end of the presentation. If you have questions, please submit it through the Q&A box and I will be happy to answer them. In the meantime, I'd like you to focus on the last examples Mona just showed you, because it is really an exam questions. And for these examples, you need to evaluate 3 things. You looked at the ABI, as she mentioned, and also towards the segmental pressure. And she just said that the segmental pressure difference should be within 20 millimeter mercury. If it's more than 20 millimeter mercury, then you would suspect underlying disease. And the last thing is the PVR, pulse volume recording. And she already showed you the 5 categories where you can classify the disease category normal towards vascular occlusion. I see people ask about the CME. That's the only thing they care about so far. Yes, we are submitting this course lectures to get the CMEs, and we will update you about it soon, inshallah. Okay, الله يعطيك العافية منى، ما قصرتي، تعبناكي معنا.
دكتور، لي الشرف والله، شكرا.
الله يجزاكي خير.
Any question you can contact me in my email or something. I can provide you with more details of the charts.
Thank you very much. Yeah, if you don't mind, can you share with us the references so I can send it to all the lectures?
Yeah.
الله يعطيكم العافية وتصبحوا على خير.